Thank you for that wonderful introduction, Izzy. Yeah, as Izzy mentioned, I've sort of had about 27 years experience as a health policymaker, but throughout my career, I've been a research engaged policymaker, and I currently have a role at the University of Sydney as a professor of public health, but I also work 1 day a week in a health service university partnership with 5 what we call local health districts within New South Wales, which is Australia's most populous state, and you'd be familiar with the city of Sydney, which is arguably the most famous city from Australia, with the Harbour Bridge and our Opera House. But it also is a very multiculturally diverse population. It's one of the most multicultural populations in the world, followed by Melbourne and parts of Canada, but also London and sort of certain cities within major countries around the world. But we are a particularly multicultural country. I myself come from a Croatian background, and my partner is from a Cypriot background and came to Australia as a refugee. So we love Australia. It's a very open country, and it's been an amazing place to grow up. So I'll talk a little bit about some of the stuff that I've done as a policymaker to sort of set the scene to why I became interested in Scale Up. So I've sort of worked in a whole range of different things, including health initiatives, primarily in the space of chronic disease prevention. And I was involved in the creation and funding of a number of large-scale pilots of the implementation of obesity prevention programs across whole communities in Australia, which were subsequently scaled up across the whole system. So, for example, there are, and Megan would know this, some of the nutrition and physical activity programs that are offered within New South Wales reach up to 90% of children. So it's very rare that you get a single program in a context that sort of reaches that many children. But we also have, I was involved in setting up something called the Get Healthy Information and Coaching Service, which is a free telephone-based coaching service to help people to achieve their health goals, but primarily to help them to reduce chronic disease risk, based broadly on diabetes prevention programs. Also helped set up a number of partnerships, which set up large programs of research with the university sector. So the New South Wales Department of Health could collaborate very closely with researchers over a 5-year period to work on a program of research. I've also overseen for the New South Wales government training programs in public health, biostatistics. I've also helped set up some research funding schemes for the New South Wales government and oversaw those, but also did some really interesting impact evaluations of research that's funded through those schemes. I've also been involved in development of government evaluation guidelines. So in 2016, the New South Wales government created a guideline which not so much mandated, but really encouraged all government departments to evaluate their policies and programs. So I was involved in setting up that process. And most recently, and perhaps one of the reasons why I think I did decide to go to academia was after working in the COVID pandemic. It was a very sort of tough couple of years, and I know it's was even more so in people around the world. But I was involved in the workforce surge, helped set up a COVID research program of research there, was involved in COVID modelling, and sort of oversaw priority research projects, which was an amazing experience. And I suppose across that period of time, one thing that I've come back to again and again is the importance of, if we do generate research evidence and we don't scale it up across whole systems, really, it is a challenge, and we're not really giving the community the best opportunity, the best available evidence, and ultimately the best sort of health outcomes that they can, which is the next slide here. Just to sort of reiterate this point, so this is a study that was conducted by Runciman and someone in Australia called Jeffrey Braithwaite. Some of you who are aware of sort of what we call learning health systems, and it's a sort of growing field now, may have seen Jeffrey Braithwaite's name, but he's done studies in high-income countries, primarily the United Kingdom, Canada, and Australia, that consistently shows that in our systems, about 60% of the care that patients receive is actually based on high quality evidence and is aligned with clinical guidelines. About 30% of the care received is low value or no value care, and about 10% of care received is actually harmful. So this finding it's quite amazing. It's been over about 15 years and it's been consistent across different settings. The other sort of important context that we have here is that really we know a lot about what works now. So the traditional model of science is that we need to constantly innovate, introduce new practices. And Emmon and Colditz did a bit of a review in 2017, and they estimated that in the past 2 decades, more than half of the cancers could have been prevented by applying existing knowledge, as opposed to sort of introducing, even if we weren't to introduce new innovations into the system, which highlights the importance of implementing at scale. So if you look at this same challenge in low to middle income country context, the challenges are amplified even more. And those are having a bit of a read of the literature. Obviously, there's a resource and capacity constraint there, which amplifies some of these challenges. And those of you from low and middle income countries today would be fully aware of some of those challenges. So this is a real challenge, and the only way we're going to really optimize the benefits of health interventions and health research really is to scale up interventions. So what is scaling up? Well, scaling up is deliberate efforts to increase the impact of successfully tested health interventions so as to benefit more people and foster policy and program development on a lasting basis. So that definition comes from the WHO, the ExpandNet definition, and it has some important components. The first of which is that scale-up is a series of deliberate efforts, and it's taking successfully tested health interventions and really attempting to benefit more people. So where does scale-up fit in implementation science? Well, the term scale-up really did even precede the implementation science. Implementation science, for those of us who've been around for a while, there were sort of different words for implementation science. There was, initiative evaluations, process evaluation. But as this field of implementation science has developed, I think the best way to think about scale-up is that really you can implement without scaling up, but you can't scale up without implementing. And implementation science is the broader field, and scale up is a particular action that one takes. And often scale up is done by people who are often research starts with the research sector, but ultimately scale up is often done by research funders rather than researchers, but often and should be done in collaboration with researchers. So what do we know about scale up? Well, scale up is generally non-linear from my experience, and certainly the reading of the literature in high income and low and middle income country context is that it's inherently complex and often political. And when we are talking about large resources and implementing change across whole systems, it tends to be often political. And when we're talking about the types of interventions that we would scale up, there are lots of different things that can be scaled up. It's not just models of care or a drug or a vaccine, but it's both public health and clinical care measures. It can be drugs, technology, vaccines, vector control, health education, behaviour change strategies, but also it can be things such as regulation, better planning, and even changes to management methods within context. So, and some of the types of things that we do scale up, incorporate multiple of these domains. So the reality of scale up in the real world is that really research evidence is only one part of the information that's used in scale up processes. We know that depending on the nature of the intervention, that there are a myriad of influences on scale up. But if there's one message I would sort of I hope you would take out of today's presentation is that we should try to make research evidence a larger piece of that jigsaw puzzle there. It certainly is involved in scale up, but we should try to introduce research evidence throughout the scale up process. So when we're thinking about the types of research that is done that really leads to effective scale up and then what system-wide adoption, this is a framework that was developed by Don Nutbeam in Australia. Don is a former head of Public Health England, head of the School of Public Health at University of Sydney, but a well-travelled person. And he talks about these different typologies of the types of research that can take place, and it includes implementation science typologies here. So we have idea generation when we are thinking about how we would solve a problem. We have feasibility studies, which are, is an innovation practical to implement and acceptable to different target audiences? Then we move to your more traditional efficacy studies that ask the question, can an innovation be delivered and result in outcomes under the best possible circumstances? Often those efficacy studies are done under far more controlled conditions, which are less like the real world and perhaps using different resourcing profiles. Then we have replication and adaptability, which is the next typology. And that asks the question, can that innovation reproduce those same impacts with different conditions or with different populations or different settings? Then we have effectiveness studies, and the important thing about those effectiveness studies is that they are testing these innovations to see whether they can achieve the same health outcomes under normal operational conditions in health systems or in communities. So often they need to be done in a way that is feasible using staff that are within that environment. And then scalability asks the question, how can an innovation be integrated into wider health systems or communities? So it's a bigger question. Another way of thinking about scale up, and this is more of a funder perspective, is that often we are thinking about how we can take a program or an intervention and how we can sort of begin to pilot it in some districts, how we can then expand it to multiple districts, and then how can we institutionalize it or harmonize it across health systems. So if we are to think about scale up, I think it's useful to think about it as a continuum. And you can, the scale up process can start with local pilots and research studies. But if it's ever to achieve those outcomes that we were talking about, those positive health outcomes, we need to increase it in a stepwise fashion across a district, across many districts, state, national, and international. And one of the most important concepts as part of that process of scale up is reach. And reach is the absolute number and proportion of individuals from a target population who are willing to participate in a given initiative. So if we are looking at sort of more universal programs, for example, if we want to do vaccination, we would hope to sort of achieve levels of reach for that target group for that vaccination. We're not hoping to reach people that are not being vaccinated for that particular condition. So we really have a denominator and a numerator, which is reach. The other thing that is equally important when we're thinking about scale up is adoption. And adoption is the absolute number and proportion of settings and staff willing to implement an intervention. So essentially, you could have high levels of reach in pockets of a district. However, if we don't have high levels of adoption across that whole district, you're not going to ultimately achieve the level of reach. So it does require consideration of both the reach you hope to achieve and adoption. And if you can achieve both of those, that maximizes your health impacts. So this is a study that myself and colleagues did that we attempted to actually see, there was nothing in the literature at the time that talked about the pathways to scale up. A lot of people had case studies of scale up. They're there's not that many, believe it or not, but there were case studies of it. But really the progression through the use of different types of evidence in the development of scaled up interventions was really unclear in the literature. So what we did is we identified through a systematic review scaled up chronic disease prevention interventions, and we backtracked them to determine what research evidence was used to inform their development. And what we did as part of that process is that we identified 4 typologies. And the first typology was a comprehensive typology. We found that these particular interventions were based on an initial great idea, involved efficacy testing, went through a real-world trial, and then were disseminated across whole systems. We also identified a typology called efficacy emitters, where there was a great idea, where there wasn't a trial associated with it, but then it jumped to a real-world trial and then was ultimately adopted across a whole system. The third typology was where the great idea started, there was an efficacy test, which is much more controlled and limited and often more resource intensive, which jumped straight into system implementation. And the final typology that we identified was really these interventions were a great idea and there was no discernible evidence on which they were based, and they were implemented across systems. Now, I've just got a quick poll for the audience. If you could tell me which pathway do you think was most common in the interventions that we identified? Type 1, type 2, type 3, or type 4?
Yep. Nearly everyone's voted now, I think.
Okay, great, Izzy. So I haven't got the information in front of me. Could you read out the responses, Izzy?
Yeah, yeah, Sheree, are you able to share those results?
Oh, okay, great. Yeah. Wow, that's pretty good. Yeah. So the actual answers were, these are the proportions. I'll sort of click those up on the screen now. So 55% were comprehensive of the interventions that we identified. 5% were efficacy emitters. 25% were trial emitters, and concerningly 15% were at scale dissemination. Now, this study was clearly biased because these were examples of interventions that were available in the grey and peer-reviewed literature, and the reality is that there are hundreds, if not thousands, of interventions out there on which there is no available evidence. So I suspect that the proportion of interventions out there that are based on poor to no sort of evidence would be much higher than this. But anyway, it's good to see that there was a spread, but concerningly about 15% were based on no discernible evidence. So what does scale up require? So irrespective of whether interventions are being implemented in low and middle income or high income contexts, we do know that really effective scale up does involve multiple levels of action, and that could be at the individual/patient level, the provider/team level, at an organizational level, and often at a system and community level. And there are lots of things that sort of change when you are taking something from a research trial and applying it across systems, is that, as I alluded to previously, when you are doing a small trial in a limited number of communities, you have a lot more control over delivery. However, when you begin to implement interventions across whole systems, you have less control over the delivery. Often when you implement things on a small scale, you're trying to prove that this intervention is effective. When you're implementing things on a system level, it's often not possible to really get those outcomes, and what you're hoping to do is develop a monitoring system for implementation. And they may not be direct outcomes, they may be precursors to an outcome. Often when we talk about smaller interventions, we're talking about individual capacities of people who may be implementing the intervention, the delivery agents. However, when we're implementing things across a whole system, we need to focus on organisational culture and building organisational capacity. And often when we are putting things in a research frame in a small trial, we're often dealing with a series of early adopters. These are people who are passionate about an issue, who are really motivated and interested. However, when we're implementing things across whole systems, we are implementing things with a workforce that has different workforce capabilities, has different interests. You may have some that may be highly interested, a group that's not really interested, but will do it if given the right supports, and some people may actively fight change. So it's a very different environment when you're implementing things across whole systems, which I'm sure in your lived experience is a very common one. So there are scale-up frameworks out there, and the most commonly used framework is the WHO ExpandNet framework. I've also developed a framework for the New South Wales Ministry of Health, which is a much shorter version of a scale-up framework, and you might want to look at that as an option. But this is the details of a review I conducted some years ago now on different scale-up frameworks. And the Global Alliance for Chronic Diseases also has funded a range of studies. I think it was the 2019 round of funding round that sort of specifically focused on scale up of hypertension and diabetes programs. And a study here was conducted looking at some of the characteristics of the funded research, and the funded projects use a variety of conceptual frameworks in the development of their proposals, including the REAIM framework, which I'm sure you're familiar with, developed by Russell Glasgow and colleagues, the Consolidated Framework for Implementation Research, to ExpandNet, the Institute for Healthcare Improvement going to full scale model, and then also a number of the grant recipients use the MRC framework for complex intervention. So there's lots of different ways to put a conceptual basis on scale-up efforts, and there are some examples here that have really been used by GACD as well. So what are some of the common features of these scale-up frameworks? Well, we do know that there are a number of important steps, and I don't have the time today to go through each of these, but the majority of frameworks talk about the importance of a step called scalability assessment. And what scalability assessment is really going through a process to determine what intervention one should scale up. So scalability is defined as the ability of a health intervention shown to be efficacious on a small scale or under controlled conditions to be expanded under real world conditions to reach a greater proportion of the eligible population while retaining its effectiveness. Now that's a very long definition, but there are important elements to it. The first is that it's a characteristic of an intervention, and ideally the intervention should be efficacious or effective, and it needs to be expanded under real world conditions to then reach as many people as possible, and ideally while maintaining its effectiveness. So why do we assess scalability? Well, obviously it's good to know whether interventions are suitable to scale up. Wherever possible, we should be trying to make those decisions evidence informed. A scalability assessment can really help identify factors that may help or hinder scale up. And it can help to think through who should be involved, what workforce should be used, where are gaps in the evidence base, and hopefully this process will improve the likelihood of success of those scale-up efforts. Now, I haven't worked out a way to actually empirically test this, but certainly that's our assumption going into this process and developing this tool. So there are a series of different scalability assessment frameworks that are available, some that were developed in low and middle income country context, and this is a review by Ali Ben Sharif, of which myself and Luke Wolfenden were part of, led by France Legare, that did a bit of a review. And one of the studies that was listed here and the scalability assessment tools is one that I developed with a colleague of mine, Karen Lee. So the intervention scalability assessment tool is a tool for policymakers, practitioners and researchers, and it's designed to assist in making assessments of scalability of interventions, to identify and assess contextual factors that may help or hinder scale up, to help determine how to design a program or an intervention for implementation or future scale up. It can be used to make comparisons across multiple programs or interventions, and it's often completed through a group consensus process, or surveys. So there are two parts to the intervention scalability assessment tool. The first part is actually gathering information through document review and the best available evidence. And this is really primarily a desk-based exercise where if you are hoping to solve a problem, this is where you begin to gather the epidemiological evidence around the nature, size, and scope of problems, and being very precise about what your target group is. Then it's consideration of the likely interventions that might be able to solve that problem based on the best available evidence. Considering the strategic context, what is the priority for the system at the moment, where would the available funding may be. Thinking about the quality of the evidence on which the scalability assessment can be made, and if possible, and ideally, having information about costs and benefits. So this information is taken into a consensus process and discussed. But the other part to the scalability assessment tool is more of a future planning tool. Now, taking all of the information that you've developed previously, you now give consideration to whether the intervention can be implemented with fidelity or it needs to be adapted to the local context. Because we do know that there is something called a scale-up penalty, where as you implement things at scale, there is a drop in the effectiveness of interventions. So you really need to balance the fidelity and adaptation to local context. You need to consider what your ultimate goal is for reach. Do you want to reach 50% of the eligible population? Will that be acceptable? You have to consider the delivery setting and workforce. There may be cheaper ways of delivering an intervention. The research literature may say that a physiotherapist would be responsible for implementing a falls prevention program, for example. But in Australia, we tested using exercise workers who were half the cost. So you may want to change the workforce. You need to consider infrastructure, but also the sustainability of the interventions and what types of infrastructure is required for implementation, IT systems, cold chain. There are a whole myriad of sort of infrastructure questions that need to be asked when you're implementing at scale. So this was what comes out the other end of the scalability assessment. You get a assessment on a like at scale, and it highlights where there are weaknesses and where there are strengths. Now, this is a qualitative process that's done through group consensus or through surveys. But it can be used to compare multiple interventions. And I've got a paper there where it was recently applied in Ireland to assess the scalability of a falls prevention program. But I know it has been used in a number of different places in Australia by governments, but they haven't published the results. And we've also piloted it with 5 different interventions recently. So in conclusion, implementation of effective health interventions at scale is essential to improving population health outcomes. So we'll only ever sort of really reach that full potential of those amazing pieces of research and evidence unless we can implement them across whole systems. And investigation of the optimal ways to expand programs really continues to receive inadequate attention in the literature. So we've done several studies, myself, Luke Wolfenden, and colleagues over the better part of 15 years, and studies that focus on scale up are still a very small proportion of the total peer-reviewed literature, less than 2%. Despite all of the efforts by funders to fund more implementation research, going to that next step of going to scale still is challenging, and effective scale up really does require the systematic use of evidence in many forms, and ideally it should be linked to decision making throughout the process. And that starts with scalability assessment, but that evidence should be used in the planning for scale up, but also the monitoring and evaluation of interventions as they're implemented across whole systems. Thank you very much.
Brilliant. Thank you so much, Andrew. And round of applause. I know it's so much harder on online, but everyone, if you could do some reactions or turn on your your cameras just to show a bit of appreciation for that. Just going to stop that sharing. Great. So we do have a bit of time for questions for sure. And there's a lot to take in there. I think you managed to squeeze in a lot of info in a short amount of time. So do we have any questions? Any hands up? What do you want to hear from Andrew while we have him online? This is a great opportunity. I will give everyone just a few seconds to digest that and formulate their questions. But to get us started, I will ask Andrew if it's all right. With scalability from your perspective and all the work you've done, should it always be assessed before going to scale, or are there situations where it's not relevant or it's less beneficial?
Yeah, look, I don't think you need to necessarily do scalability assessment with every single intervention. It really depends on the context and the amount of evidence that's available for a particular intervention. So some interventions have overwhelming evidence and they're being applied to, for example, that's maybe taken from a high-income country context to a low and middle income country context. You know that there's good evidence, but it hasn't been applied in that particular setting. You might want to, in that case, apply a scalability assessment and think through the differences in the context. If you're taking an intervention from a like context where it's already been shown to be relatively effective, but hasn't been able to achieve levels of reach, well, I think you can just assume that, it's a good thing to do. You should be sort of trying to scale that up and then focus on your implementation strategies to help increase the potential reach and adoption of that intervention. So scalability assessment isn't something that needs to be done on every occasion, but if there are occasions where you are entering into a situation where there is an absence of evidence and you're trying a new intervention, I would have to say, in an ideal world, you should be using a scalability assessment. Yeah.
That's fantastic. And are there any questions from the audience? Any hands up? Or feel free to pop it in the chat if there's anything that comes to mind. Samina, please go ahead.
Thank you, Andrew. So I'm actually struggling to understand that when we should use the word scalability. So taking an example that I have an evidence-based intervention to increase the physical activity. So I'm going to implement it at the district level, or I'm going to implement it at the provincial level or national level. At 3 levels, we are calling it scalability. So do we have some cut points that this number of population, this number of geographical area, if we will cover, we will call it a scalability?
Yeah, look, that's always a challenging thing. And that's why I put that diagram up with the reach and adoption, because often I've been at conferences and people talk about scale up and effectively what they're doing is a pilot in a couple of sort of settings. So it's not truly scale up, but that said, if you view scale up as a continuum and your ultimate goal is to sort of increase its reach across whole systems, you may be at the beginning of that journey, or you may be in the middle of that journey, or you might be at the end of that journey. So I think you can use the term scalability or scale up when your intent is to sort of increase the reach and adoption of interventions across systems. So you just might be, Samina, at the stage that you're early in that process. So, or you may be further down the track. Often it's used almost universally. So I've seen it sort of used in lots of contexts because it's can be a buzzword. But what you've described does sound like a scale-up process because you are trying to sort of move it across from local settings, then across a province, and then expand its sort of application across populations.
Yeah, thank you so much. And second thing, I think then it becomes very difficult to evaluate and, to monitor if we are going to really monitor our intervention in a real world setting, because there are many other factors also involved in this.
Yeah, and look, this is one of the challenge in any scale-up process, irrespective of the context, whether it be in a high-income country or a low-income country. The actual resources available for a scale-up evaluation and monitoring will never be enough to sort of do the ideal evaluation in the real world. And the challenge is, often you need to sort of pick from a variety of available measures about those that you could resource in that context. And often one way of thinking about it, Samina, is that if you can demonstrate that there's effectiveness of an intervention on a small scale, you may not have the ability to measure those outcomes when you're implementing at scale. So what we've done in New South Wales in Australia was that we did a series of randomized controlled trials of interventions that were implemented. We implemented them across 2 local health districts. And then we sort of saw that in the real world, in that local health district, it still achieved a level of effectiveness. However, when we implemented it across the whole state, we used proxy measures. We didn't do the outcome measures anymore because we just assumed that we knew from the previous studies that if we do change people's knowledge, behaviour, that this is the likely outcome, because we just didn't have the resources to do outcome evaluation. So it's a case of sort of prioritising the types of measures that you can do, and you could have high quality evidence that's used periodically throughout the process. But what's important to measure from our experience is the reach and adoption of your intervention. So if you were to prioritise the resources, those would be the 2, and often they can be things that can be sort of more readily measured. And then you could go in periodically and try to measure outcomes. So it depends on the intervention, depends on the context, but it is a real challenge not having enough resources to do a comprehensive evaluation.
Great, thank you so much. And we've got another hand up. Gianni, do you want to ask your question? I'm sure we've got time for this one more.
Hi, thank you, Andrew. This is Gianni from Deakin University. So you mentioned that the assessment tool was used in government and practice settings, but they're not published yet. Can you give an example on how the tool was received in among this group, and have there been any success in translating those scalability outcomes into something, the decisions that they make in the end?
Yeah, and this is where the politics comes in. So I had used it on several occasions as part of government deliberations. So these weren't sort of open processes. So the reason why some of those examples weren't published was because they were part of a government decision-making process. So they haven't been released. So I can say that of the 3 times that it was applied, interventions didn't proceed. So that were being put forward based on the scalability assessment. We did a pilot test with governments across the country. So Karen and myself did that. So there's 5 interventions, and that's a published paper where those assessments were made. So that's available. And the example in Ireland of the scalability assessment was for a falls prevention program, and that was published as well. So there are 2 studies, but 5 examples of where the scalability assessment has been used. The tool is currently being used in a number of studies within Megan's area as well. Scalability assessments are being done in a number of trials as part of those interventions as well to assess the scalability of, so there's a systematic review of vaping interventions that's currently being conducted by Luke's group, and scalability, we are going to assess the scalability of promising interventions identified through that. It's not a government process, it's basically an academic exercise that will be providing advice to the broader field about whether those particular interventions are scalable. So it can be used in government decision making. It can be used as a gap analysis to really see where you need to gather additional information to strengthen a case for change. It can be used to help build a case for change, but it's also been used to stop interventions that may not be fundable in a context by organisations as well. So it's used in a lot of different ways by different stakeholders.
Thank you.
That's great. And I can see there are a few questions coming in the chat, but I'm also very aware of the time here. So we may have to draw a line at questions for live, but I'll ask Andrew, would you mind taking on a few questions on our Padlet board? It's our digital notice board for everyone. So if they have a burning couple of things, perhaps you could pop a couple of sentences on there, if that's okay.
Yeah, no problem at all. Happy to do that. And so
Great.
I can do that later or so?
Yeah, absolutely.
Yeah,
So it's
great.
this Padlet board for everybody. It's going to be open for another week. So you can have a chance to connect with people that you've met with today. And also if you've got any burning questions, of course, if there are hundreds and thousands of them, we can't expect Andrew to go through all of them in detail. But if there are a few on there, then hopefully some helpful answers or signposting in the right direction would be the way forward.
Yeah,
So
very happy to do that, and very happy to thank you for the opportunity to come and chat. And you're also happy to chat further. I'm new to academia, so yeah, I'm happy to start conversations with people. So yeah, please
excellent.
reach out.
Thank you so much. And once again, just a round of applause for Andrew. Thank you for joining us and for sharing your expertise and your experience. So thank you very much.